Hi everyone, so now we're going to show you how to suction a tracheostomy on a ventilated and a non-ventilated patient. You've likely already seen how to suction a tracheostomy, so we'll remind you that piece and then we'll show you how it's different when the patient is ventilated via a tracheostomy. So the patient here right now is just on non-ventilated essentially, so would be likely on high humidity over this tracheostomy. So we've removed the high humidity for now to be able to show you the procedure. One thing to think about, obviously, in your assessment prior to starting is how well are they going to tolerate being suctioned. If there are any issues with their SpO2, their oxygen saturation, their respiratory rate, etc., these are things that we will want to get completely organized before starting the procedure. To ensure that we minimize the time that this patient is without any oxygen. So right now, when you think about suctioning a patient that has a tracheostomy, you always want to ensure that there are actually signs that they require this. We don't suction patients on a regular schedule. We really only do it based on clinical indication. So someone that you can hear that has some gurgling, you can auscultate some rhonchi, which means that there's likely secretions in the larger airways, when their saturation might be dropping or they're breathing faster, and you hear them coughing and trying to clear out the secretions. These are the type of reasons why you would go and suction a patient. So here on this tracheostomy is the cuff of the tracheostomy. So if this were out of the patient, it would look like this. So you do have a cuff right now. So in critical care settings, most patients have cuffed trachs. And that's because if they are ventilated, so we have a ventilator that's connected here to the tracheostomy, we're pushing air into the tube inside the hole. And we don't want the air to come out from around it once we push the air in. So it goes in through the hole, comes into the lungs. We don't want that air to leak out around. So there's a cuff here that really closes off the airway to ensure that all the air being pushed in remains inside the lungs. And that the only way to come back out is actually back through this hole here. So this is why there's a cuff here. So we know that it's a cuffed trach. And so not only will we go suction inside the tracheostomy tube and down into the lungs, but we'll also have to go suction around the cuff here, and we do that by going through the mouth. So we'll show you both aspects of suctioning essentially. So what you will need is definitely suction. So this tubing here is connected to a suction device, and your suction, you would set it between 80 and 120 millimeters of mercury for the suction. That would be the ideal place to ensure that you're not essentially suctioning too hard, and that could cause some tracheal damage essentially to the mucosa. So you'll need your suction ready. You'll need your suction catheter ready. So for an adult, normally the size of the catheter should be between 10 and 16 French. So here we have a 14 French in this case. And you'll also need some normal saline. You could also use sterile water as depending on what you have on board or depending on the hospital's protocol. When doing this procedure, obviously when you enter the room, you would do your hand hygiene. So perform hand hygiene, and you would put the proper protective equipment. For a patient that has a tracheostomy that is open, so a non-ventilated patient, this is an aerosolizing producing procedure. So someone that you don't have any concerns that they might have tuberculosis or even coronavirus, you could wear a mask, a regular surgical mask, and a visor would be a good idea in case there's some secretions that splash. And someone that you would be concerned that has a bit more of an airborne precautions, you would wear an N95 mask in that situation. So based on your patient, you would choose the proper protective equipment. So if we start, so you can assume right now that I'm wearing the right equipment and we're ready to start. One thing to think about with these patients is that Sometimes they're able to tolerate well the procedures, and other times they actually might need to be pre-oxygenated, so hyperoxygenated, which means that we would give them a bolus of oxygen of 100%. Someone that is not ventilated, we would actually have to do that via a bag mask valve. And so the way to do this is actually, this is connected to oxygen. We would bring it up all the way to the maximum, which is 15 liters, and we would actually go and pre-oxygenate by connecting directly to the tracheostomy and giving them the required pre-oxygenated breath. These are going to be 100% breaths that you would give. You can give 2-3 of them and check their saturation, ensure that they're saturating well before you start the procedure. From there, you would be able to open your equipment and to get ready. You can obviously do this step before you actually ventilate them. That would probably be the best thing to do. So we can do the proper steps after you open your tray here. In your suction catheter tray, you have sterile gloves that you can easily slip on over the gloves you're currently wearing. You have a container here for some water, and you'll have your suction catheter. Now, one thing to remember is that you have one hand that will be dirty and one hand that will be clean. Normally, your dominant hand would end up staying clean, so stay sterile, whereas your non-dominant would get dirty, essentially. I'm a left-handed, so my dominant is this one here, the left-hand side. So I would take my right to be able to touch what I need to touch. So at this point, I would be ready to start, but this is where you would actually give some pre-oxygenated breaths to your patient. Take your bag mask valve, connect to your patient, and give them the required breaths that they would need. From here, this is my sterile hand. I can connect. And now I would go inside the lungs to suction. So one thing with suctioning is that you can do deep suctioning, which essentially means that you're going down all the way until you hit resistance, which is at the carina. You would pull back 1 or 2 centimeters, and then you would start suctioning. The other option is that if it's just secretions that are in the airway, in the larger airways, and you don't feel like you need to go that deep, that's just they kind of sound like they're near the throat, then you do not have to do deep suctioning, and you can just insert until you feel like you've gone far enough, essentially. So after suctioning your patient once or twice in a shift, you'll have a pretty good sense of how far down you have to go based on their needs. So for this section, you can either continuously suction on your way out only. When you're going down, you never suction, only on the way out. You can either suction continuously or intermittently. Either one of them, there's not one that causes more mucosal damage. They're essentially the same when it comes to any type of damage that you would have. There's also the idea that, we can kind of rotate the catheter to try to get all the edges. That is something that could be done, but is not necessarily required. And the last thing is also that if you do intermittent suction, is that if you are going and doing deep suctioning and you have a mucus plug that has formed, if you are going to intermittently suction, there's a chance that you will, initially suck that plug, but then you'll end up dropping it once you do your intermittent suction. So depending on your patient, you can see what's most tolerated and based on their needs, essentially. So from here, we would be ready to go down. And so we would go down into the tracheostomy. So I feel resistance here. I would press here on the button to suction, and I could just suction out not too slowly, because the suctioning is the difficult part for patients. So you want to be able to go in rapidly, and when you come out, you don't want to go out too quickly, but you don't want to go too slowly. So you just have to do it in a bit of a seamless motion. From here, because this catheter is going to be dirty, we can go into our sterile water and suction to clear out the catheter, to clean the catheter in the event that we need to return another time and to go suction one more time. So now I have a clean catheter. I don't have a lot of secretions that have built up, and I'd be able to go again. If they don't need it, don't go again. But if they do need it, go until you're able to clear everything you need to clear. So we go back down, hit some resistance. I'd pull back my 1-2 centimeters, and now I would press on my suction and I would pull out. Again, I would go and rinse the catheter. If that was enough for them and they didn't need to be suctioned again, I would completely rinse the catheter very well on the outside and the inside, because in the lungs we really want to be sterile, but now we have to go get some of the secretions that might be caught in the back of the mouth and above the cuff that we talked about on the tracheostomy. So once this is fairly clean, it's not sterile anymore obviously, but it is clean, I would actually go in the mouth until I get resistance, because that's where your cuff is, and I would suction out around that area. So you could probably move a little bit because there might be some saliva and secretions on both sides of the mouth, and you pull back out. Obviously this might elicit a gag reflex in a lot of our patients, so we try to only go once, but it is very important to capture all of those secretions above the cuff. Otherwise, there will be micro leaks into the lungs, and that could cause a ventilator-associated pneumonia or just a pneumonia if they're not being ventilated. From here, there is always a way to not contaminate yourself when you're about to throw your catheter so that it doesn't splash into your face or anything like that. Just wrap it around your hand, disconnect, and cover your suction catheter and toss it in the garbage. And then you'd be able to, again, your post-suction assessment to verify, ensure that your respiratory rate is better, that your saturation is better, and that the distress that the patient had that indicated that you needed to suction is gone. And if they were wearing some oxygen, you would obviously want to put the oxygen back on as soon as possible and put everything else away. And that would be it for a patient that is non-ventilated. We're going to talk about suctioning a patient with a tracheostomy, but that's being ventilated. So before we showed, there was a video on how to suction a patient that has a tracheostomy that's not ventilated. So the difference here that you can see is obviously that he is connected to a ventilator, and that he actually has this additional piece to the ventilator, and this is what we are going to use because this is called an inline suction. So it's actually connected directly to all the tubing for the ventilator, and is also connected here to our suction, on our wall suction. So the big difference is that this system is a closed system, which is beneficial in many ways. One of the reasons is that patients that require PEEP, so positive end expiratory pressure, to help support their oxygenation, this way we don't actually have to disconnect the system, and they won't lose that positive pressure that's in the lungs, that's allowing the lungs to stay open. Even on expiration, they stay open, they don't collapse, and it doesn't create as much atelectasis so that the alveoli are available for gas exchange. So by having a closed system, the PEEP remains in the lungs, so we don't lose that air and those open alveoli. It also decreases any risk of contamination just because it's a closed, clean system. So a patient that's being ventilated like this, and that, you know, either you can almost maybe hear some gurgling. If you put your hand on their chest, you would feel the chest vibrating. If you were to auscultate, you'll also hear some rhonchi. And you might have signs of respiratory distress, a decrease in oxygen saturation, an increase in respiratory rate. etc. Or the patient might actually be trying to cough and is unable to clear their secretions. These are all indications that you might need to suction a patient. And this is something that as a nurse that you can do, assuming that you have done it before, that's been supervised, and that you feel comfortable doing it, and that you know the actual procedure to do so. Otherwise, respiratory therapists would be the ones coming in to do these suctions. So you would want to ensure that your patient is stable enough to be able to get suctioned before you initiate any suctioning. So as the patients that were non-ventilated, hyperoxygenating the patient is a good idea so that they better tolerate the procedure. When they are ventilated, there are often a button on the ventilator. In this example, it says there's an upwards arrow and O2. It's actually an oxygen bolus, so it's an 100% oxygen bolus. Sometimes it'll be written O2 100% or O2 bolus. So to hyperoxygenate our patient, we would actually press on this button. It would say on the screen that we're delivering an oxygen bolus, and once that's done, and our patient appears ready and they're aware of what we're going to do after we've told them and explained to them what we're going to do, we could go ahead and suction our patient. So the way to do this is that there is a button here, but it's locked. It should be locked generally speaking, but we would have to turn it so that it would be unlocked and we'd be able to press down. Now every time you press down, it actually suctions. So you don't want to be doing that as you go in. You only want to be doing it as you come out. So these inlines, I can show you another example here, but this is a longer one for an endotracheal tube because there's a further distance compared to a trach. A trach removes all this space here, this dead space, so the tubing is much smaller or not as long. So the way that we do this is that there is a suction catheter inside. It's covered with a plastic sheath to keep it sterile and clean. And what we do is that we would just push this into the lungs. And then you would feel that resistance. You would pull out 1 or 2 centimeters, and then you would press on this suction button and pull out to suction your patient. This little black line here should be outside and you should be able to see it. And that's ensuring that you're not obstructing any of the airflow. So in this example here, so once our patient is ready, we've hyperoxygenated. We want to make sure that we're holding the tubing just in case that it kind of pops off. We don't want it to pop off because, that could have some splash. And so in this case, we would go and push down into the lungs. So assuming I could push down, but I can't here, I push down, feel resistance, and once I'm where I'm at, I would pull back just 1 centimeter and then press on the suction and suction out until my black line appears. So once I'm done that, I would lock my device to ensure that accidentally, the patient's arm doesn't go against it and it stays continuously on suction. We want to ensure that this is locked. So if the patient is doing well like this and we don't need to return, then that's good. But if we were to return again, we would hyperoxygenate once more. So we would press on our button here, unlock, hold our tubing, inform the patient that we're going to go in, push our tubing in, hit resistance, pull back 1 or 2 centimeters, press on our button, and suction out by pulling. Okay, and now again, we have our black line that we can see here, so we know we've come out. Now, if this is full of secretions, one thing that we can do is actually there's a little port here that we can connect they're kind of mini syringes of normal saline. They're often pink, or sometimes they're just clear. And we're actually able to connect that here, squeeze the NS bottle as we're squeezing on the suction. So obviously we want our patient to be much higher up because we don't want that normal saline to go in the lungs. We want it to, as we squeeze over here, say there's a piece here, and we suction, it's just going to come up and into the tubing to clear it out of secretions. So that's the best way to clean your tubing. So the idea of instilling normal saline into the patient's lungs is one of those things that actually we used to think that it would liquefy secretions, but it actually does not liquefy secretions. One thing it does do is elicit a cough reflex. By putting water into a patient's lungs, obviously they're going to want to cough. And so once we instill the NS, it makes them cough, brings up a lot of those secretions, and then we can go out and suction them. But the idea that it loosens any secretions is not real. That's not actually the case. And so it's not recommended to instill normal saline into our patient's lungs, although at times you will see it done. A better option than instilling NS in a patient's lungs is actually doing chest physio and vibrations and helping them cough. So a cough assist that a lot of physiotherapists will do in critical care settings, and that will bring up a lot of the secretions that we'll be able to go suction out. So the NS really should be used to clean our tubing, should not be used to instill in patients' lungs to loosen secretions, because it does not do that. And it actually increases the risk of contamination. In the event our patient was actually ventilated, but we didn't want to use the inline suction for whatever reason, there is a way also to suction them the way that we did with the non-ventilated patient, and that would be essentially, if they are able to tolerate it, to simply disconnect them from the ventilator. And then with our suction catheter that we would normally use for non-ventilated patients, we would go in and suction our patient. So we would initially give our bolus of oxygen prior to disconnecting our patient with our non-dominant hand, using our dominant sterile hand with the suction catheter to go in and suction them as required. We don't have a tendency to do this just because we're opening up a system. We would lose the PEEP and we would risk some contamination, and also you risk to getting some splashing in your own face. So you would really have to wear the right protective equipment to be able to do this. After you've done suctioning of their lungs with the inline, there's also mouth care that could be done, and going to suction above the cuff as we did in another video. That would be another part of the suctioning that you could do, which we normally do about every 4 hours for our patients, and that we'll show you in a different video.